Okay, good evening. Welcome to the talk on our planned Deferiprone trial for children with Pelizaeus-Merzbacher disease here in Amsterdam. My name is Nicole Wolf. I'm a child neurologist working in Amsterdam on Pelizaeus-Merzbacher disease. I do not have relevant conflicts of interest for that subject. Just to tell you where I'm from, I'm working at the Amsterdam Leukodystrophy Center, which is headed by Professor van de Knaap, whom you see in the left upper corner. We are a center focused on leukodystrophies, have been for more than 20 years. We are doing a lot of MRI analysis, have defined new leukodystrophies, identified causal genes, doing natural history studies, working closely with a pediatric neuropathologist for tissue studies in order to understand disease mechanisms and also improve and develop new treatments. And now, which is very exciting for us, we are also involved in setting up therapeutic trials for several leukodystrophies. And we work with mice with stem cells, and of course, we also see patients in the course of their disease. Pelizaeus-Merzbacher disease is a disease affecting myelination. And just to recap, normal myelination is very important for brain maturation. And it starts already during pregnancy and is going on until the age of around 2 years, when it's more or less finished, completed. That's been known for 100 years already with these beautiful anatomical preparations. And myelination is also very important for our motor and cognitive development. We can follow myelination beautifully nowadays on MRI scan, and you can see here how the MRI changes from birth to the age of 2 years. Pelizaeus-Merzbacher disease is a hypomyelinating disorder or hypomyelinating leukodystrophy. That means that there is a significant permanent deficit in myelin deposited. And we can demonstrate this very nicely with the MRI. You see on the left side an MRI of a child with hypomyelination, and on the right side a neonate. And I think you all see that these MRIs look very much alike, different from a normal child. So that's what we see on a MRI of a child with hypomyelination. Pelizaeus-Merzbacher disease is a very important differential diagnosis of hypomyelination, and the clinical spectrum is very wide. We have children who are affected very severely and have symptoms right from birth, sometimes serious breathing difficulties. And on the other end of the spectrum, the mildest forms have a later onset spastic paraplegia with problems walking. And all this can be caused by mutations in the PLP1 gene. We can have several mutations. Most children have duplications of PLP1, about 2/3, and they have what we call the classic phenotype or the classical presentation. Children with other mutations in the PLP1 gene can have very severe forms or very mild forms. And that's very important to keep in mind when we think of treatment of this disease. We know from actually personal experience that the amount of myelin we can see on the MRI correlates quite well with clinical severity. So in the severe presentations, we have very few myelin we can see on the MRI, and the milder the patients are, the more myelin we can see on the MRI. We have looked at that together with a colleague, Dr. Harting, who also presented her work, and we can see that indeed when we score the MRIs following a very strict scoring system, that we can see differences, for example, between the classic PMD patients and the more severe forms regarding the amount of myelin patients make. Hopefully we will start shortly a treatment study for PMD in Amsterdam, And you heard from Dr. Roach that they found changes in proteins in iron metabolism in cell models and mouse models of PMD. And they treated the cells and mouse models with a certain drug, an iron chelator, and that was quite successful. So what are these drugs? Iron chelators are usually used for the treatment of certain blood disorders leading to many blood transfusions. They scavenge iron to remove excess iron, and they are already used in adults and children, although they are not yet registered for young children who are younger than 6 years of age. But in trials, they are already used even for children from 6 months onwards. Side effects are present in these children: nausea, vomiting, diarrhea, leukopenia, agranulocytosis, which means even the risk of life-threatening bacterial infections. The study design, we chose this duration of 12 months. The primary outcome will be motor function, and secondary outcomes will be improved myelination on brain MRI. And we will, of course, use the new scoring system developed by Dr. Harting, but also include advanced quantitative imaging to really measure the amount of myelin. We also look for new possible markers to decide on outcomes. We use call that CSF or blood biomarkers. And what does participation mean for a patient? It means taking the drug, of course, twice a day. It's a liquid formula, so that should be okay for children. It can also be given via a gastrostomy if children have a gastrostomy. We need to make MRIs under anesthesia at the beginning and after 12 months, and also do blood and CSF studies with these MRIs. And small skin biopsy at the first MRI of 2 millimeters. We do all these tests under general anesthesia. 3 monthly visits to Amsterdam for examination and more detailed blood tests. 3 assessments by a physiotherapist with a video exam. And perhaps most important, we have to take weekly capillary blood tests to check for leukopenia and to prevent serious infections. And that's really important, as when the white blood cells go down, we might have to stop the drug. And also when a child has a fever, blood has to be tested. Of course, it's not doable and not necessary to come to Amsterdam for weekly capillary blood tests. So this will be done close to patients' home. But that means that we have to have a quite close surveillance of the participants in that trial. And that also means that we will do this trial in children who live in the Netherlands or very close to the Netherlands. So why would we like to do a study? We could just treat patients with PMD with this Deferiprone. But we really want to evaluate real effects of this treatment. And you can only do that if you do it in a relatively controlled manner. So which patients will we include? Boys with the severe forms, meaning connatal, transitional, and classic forms. These are children who are not able to sit without support. And we also will include patients not older than the age of 7, because we know from older patients that they develop additional brain changes like brain atrophy, which means that we might not rescue all the symptoms in older patients. Why don't we include milder patients? Because milder patients show already better motor development and myelination anyway, so it might be difficult to separate this from possible treatment effects. So that's the reason why we are relatively strict in what patients we include and what patients we cannot include in this trial. We aim to include 5 to 10 patients, so it's a very small trial. We call that a proof of concept or pilot trial. That also means that we will not be able to see mild effects of the treatment. So if there is a very mild improvement, it will be difficult to prove that this is really coming from the treatment. So that trial is aimed at looking at robust, clear treatment effects in our patient population. Perhaps you might ask yourself whether a start of myelination is possible at all later in life. We have seen that in patients with another genetic defect, and they started to myelinate just around the age of 2 or 3 years. So we know that this is possible. So this treatment success in theory is realistic. To sum up, Pelizaeus-Merzbacher disease is a disease with varying severity. We need more information about natural history. We have now a quite good MRI scoring system, which is useful for clinical studies. And we don't have treatments yet, but clinical studies are starting. And with clinical studies, I mean Deferiprone, and in the future, perhaps gene dose reduction for the patients with duplication. And for older and milder patients, we might need different treatment approaches aimed at axonal health. Thank you very much to all patients and families, colleagues around the world, the CHOP team, of course, for organizing this meeting and the natural history study. Thank you.